Good morning. I'd like to talk to you today about simple sciatic nerve blocks. My name is Jeff Moulter. I'm a CRNA with Western Reserve Anesthesia Associates based out of Findlay, Ohio. Now, the reason I want to talk about sciatic nerve blocks and making them more simple is because I was struggling with this block quite a few months ago, which is kind of odd. I mean, the sciatic nerve is the largest nerve in the body, measuring about 2 centimeters in its width at its origination. So why would it be difficult to block the sciatic nerve? Well, the sciatic nerve, when it travels through the pelvis, is fairly deep. I mean, anywhere from 7 centimeters to 12 centimeters deep, and it lies between some muscle layers, between a few bony structures. So it can be sometimes difficult to see on ultrasound and sometimes difficult to locate with a nerve stimulator. So my goal was to make this difficult block a little bit more simple. So that is the reason for this review or conversation. Now, here's a diagram of the bony pelvis, and when we're trying to provide a block to the lower extremity, there are 5 major nerves of the lower extremity we need to consider. On the anterior side, starting from lateral to medial, we have the lateral cutaneous nerve of the thigh, we have the femoral nerve, and we have the obturator nerve. Now, when we flip the patient over on the posterior side, we have the very large sciatic nerve, and we have the posterior cutaneous nerve of the thigh, which can sometimes be called the posterior femoral cutaneous nerve of the thigh. Now, it's important to see that as the posterior cutaneous nerve of the thigh comes down through the pelvis, it actually travels in close proximity to the sciatic nerve until it becomes a little bit more distally here, it becomes more medially. So when we're talking about the various sciatic nerve block approaches, you're going to want to remember that as you go more distally down the sciatic nerve, you're less likely to catch this posterior cutaneous nerve of the thigh. I'm going to be talking about 5 different approaches to the sciatic nerve today, and those are going to be the classic approach. We're also going to be talking about the mid-gluteal approach. We'll be talking about the inferior or subgluteal approach. We're going to be talking about the anterior approach to the sciatic nerve, and lastly we'll be talking about the popliteal sciatic approach. Out of those 5 approaches, if you can master 2 of those approaches, you do not have to worry about the other 3. And those 2 approaches that you master, if you would focus on the mid-gluteal approach and the popliteal approach, there's really not a need to know the other 3, but we will cover them. Now, I like this depiction of the sciatic nerve. It's actually from my anatomy book from undergrad. Who would think that I'd be using a book from 1990 to show you anatomy? But I like how it shows the origination of the sciatic nerve here. It is formed from 2 plexi. The lumbar plexus and the sacral plexus actually form the sciatic nerve from L4 to S3 actually. And what the interesting thing about the sciatic nerve, it is actually 2 separate nerves that are combined by a fascial sheath in the pelvic area. And those 2 nerves are the common peroneal nerve and the tibial nerve. And in this depiction, they show them separate, but they actually do come together, and they are kind of connected by a fascial sheath in this pelvis area as they travel through the pelvis. Now, it's important to differentiate between the common peroneal and the tibial nerves because when we're using a nerve stimulator, we're going to want to know which part of the sciatic nerve we're actually coming in contact with our needle. Now, the common peroneal nerve, as it starts out, it is more posterior than the tibial nerve. It actually also travels on the lateral side when we're looking at a sciatic nerve. The common peroneal nerve will be more on the lateral side of the sciatic nerve. The common peroneal nerve is also much smaller than the tibial nerve. It's about half of the size. And when we stimulate the common peroneal nerve, we're going to see dorsiflexion of the foot and eversion. Again, when we stimulate the common peroneal component of the sciatic nerve, we're going to see dorsiflexion and eversion of the foot. So when you're performing these sciatic nerve blocks, it's important that you isolate the foot. Now these blocks can be performed in many different positions. The patient could be prone, the patient could be supine, the patient could be in the lithotomy position, the patient could be in the lateral position. So when you're performing sciatic nerve blocks, I would say one of the keys is that you isolate the foot so you could see the way that the nerve reacts to nerve stimulation. Now the tibial nerve is kind of the opposite of the common peroneal nerve. It does travel on the anterior side here in the beginning. It then travels on the medial side as it comes down the thigh region. It is also larger than the common peroneal nerve, and when the tibial nerve is stimulated, you'll notice plantar flexion and inversion of the foot. Now there was a study that was done that showed when you're performing a sciatic nerve block, if you're able to get tibial nerve stimulation, your odds of having a successful block go up and the onset of the time of the block go up. And that makes sense. I mean, the tibial nerve is twice as large as the common peroneal nerve. So if you're able to block that more medial side of the sciatic nerve, chances are you will get the common peroneal nerve just by the sheer fact of having the volume of local anesthetic. Now this is a depiction of the bony pelvis here from the posterior view. Want to identify some important bony landmarks. We have the greater trochanter here on the lateral side. We have the lesser trochanter here. We have the ischial bone here. We have the ilium bone here. We have the posterior superior iliac crest back here. We have the greater sciatic foramen. And looking at the different muscles, although it is not labeled here, the quadratus femoris is here on the anterior side of the sciatic nerve. We have the piriformis muscle here, which is on the posterior side of the sciatic nerve. Now it's important to note that the gluteus maximus here is peeled away. So the gluteus maximus, the sciatic nerve is on the anterior side of the gluteus maximus and is posterior to the quadratus femoris muscle in this region here. Also importantly is that when the sciatic nerve comes out of this greater sciatic foramen, it exits below the piriformis muscle and it actually travels almost basically perpendicular to the midgluteal sulcus, and we'll talk a little bit about that later. This is a pan-away view of the sciatic nerve traveling down the posterior thigh, and once again you can see it passes posterior to the quadratus femoris muscle. I want you to note here that we have the biceps femoris muscle, which attaches here on the ischial tuberosity and travels more on the lateral side of the leg. When we're performing a block in the subgluteal area, this biceps femoris muscle you will see on ultrasound. Also important to note that the adductor magnus muscle is located on the anterior side of the sciatic nerve, so that when we're approaching that nerve from the anterior side, we're going to be going through that adductor muscle, adductor magnus muscle. Also note that the sciatic nerve lies medial to the femur in this upper and mid-thigh area, and that the sciatic nerve also divides above the popliteal fossa here. It actually divides into the tibial component and the common peroneal component here. And we'll talk a little bit about that later when we're scanning in the popliteal crease. On average, it is said that 4 to 10 centimeters above the popliteal fossa that the nerve actually divides. So we commonly say 7 centimeters superior to the popliteal fossa that the sciatic nerve divides. This picture just shows you the sensory innervation. Basically, the indications for sciatic nerve block would be any type of surgery below the knee. The important thing to remember here is that the sciatic nerve does not provide any type of sensory anesthesia to the medial side of the ankle and part of the calf. So if you're going to be doing an ankle fracture, if your incision is on the lateral side, probably not much to worry about, but if your surgeon's going to make some type of incision on the medial side of the leg, then you're going to want to do a saphenous nerve block, and there are several ways you can do that. You can block the femoral nerve up high, and by doing that you'll get the saphenous nerve. You also can do an adductor canal block in this area, which will get the saphenous nerve, or you can perform a traditional saphenous nerve block on the medial side of the knee here. So again, the sciatic nerve block can be used for really any surgery below the knee. Just remember that that medial side is innervated by the saphenous nerve, so you'll need to block that separately. Now, at our institution, we commonly do sciatic nerve blocks to cover patients having ACL reconstructions. We do use a femoral nerve block in conjunction with a sciatic nerve block. And what we notice is that patients were, our surgeons prefer to use the hamstring for a graft for the ACL. And what we notice is that patients were waking up with a lot of posterior thigh pain. So we added this sciatic nerve block to our femoral nerve block in order to have complete analgesia of the lower leg. Now, if you remember what I said before, this posterior cutaneous nerve of the thigh, it does branch off from the sciatic nerve kind of in the mid to subgluteal area. So if you're going to be performing a traditional sciatic nerve block or classic approach, mid-gluteal approach, most likely you will get that posterior cutaneous nerve of the thigh. Now, if you move down and do a subgluteal approach, there's about a 50% chance that you're going to miss this posterior cutaneous nerve of the thigh. So important for you to remember, if you perform this subgluteal or infragluteal sciatic nerve block, you may have phenomenal twitches. You put your local in, you see the local go around the sciatic nerve. You'll have to remember that in 50% of those patients, you could still miss that posterior cutaneous nerve of the thigh. So the patient may have posterior thigh pain. Now, the type of equipment we use at our facility for sciatic nerve blocks, pretty common. I'm going to brush over these. We use a nerve stimulator. We use a skin marker with a ruler. We use ChloraPrep solution. We prefer Payunk needles. We use 100 millimeter echogenic needle that has stimulation properties to it. We obviously have our syringes for our local, our gloves, and we like to use 0.5% Nerapin, and we add 10 milligrams of Decadron to 30 cc's. And it seems that with these single shot blocks that we do in our facility, the patients are getting anywhere from 24 to 36 hours of block time with their sciatic nerve blocks. We typically use about 20 cc's of volume for our sciatic nerve blocks, and the reason for that is that we usually are using another nerve block along with the sciatic nerve block. So we'll typically use maybe 10 cc's of the 0.5% for the femoral nerve block, turn the patient on their side, and use 20 cc's of the 0.5% for their sciatic block. Now, I know that two people in our practice like to actually take this 30 cc's and dilute it to 40 cc's. They'll take 20 cc's and use it on the femoral nerve block, and they'll take 20 cc's and use it on the sciatic nerve block. We use a Sonocyte S-nerve ultrasound machine. We have a high frequency probe over here on the right, and we have a low frequency probe here on the left. Now, the advantage of the high frequency probe is that it shows things in more detail, but unfortunately it only goes to a depth of 6 centimeters. So the high frequency probe can be used when you're blocking the sciatic nerve at the popliteal crease, but the low frequency probe is preferred when you're blocking the sciatic nerve in other parts of the body because it does let you see deeper. Unfortunately, you do give up some of the detail when you're using the low frequency probe. Now, moving ahead, I'm going to talk about the classic approach. This classic approach was first described by Gaston Labat in 1922, And what Gaston Labatt did was he basically had you identify the greater trochanter on the lateral side and the posterior superior iliac spine on the medial side. He had you draw a line between these two bony landmarks, and right at the midsection or the middle of this line, he had you draw a perpendicular line 3 centimeters caudomedially. This then became the site of your needle insertion. What Labatt then did was take a 5 to 6 inch needle and inserted it caudomedially at this point and looked for a paresthesia. Once he acquired a paresthesia, he injected his local, and voila, he had a sciatic nerve block. By drawing this line from the greater trochanter to the posterior superior iliac spine, he's actually mimicking the superior border of that piriformis muscle. If you remember, like I said earlier, this piriformis muscle lies posterior to the sciatic nerve, and it is on the superior edge of where the sciatic nerve comes out of the sciatic foramen in the pelvis. Now here's a picture from Nisora demonstrating this line drawn between the greater trochanter and the posterior superior iliac spine. And again, this is the insertion site for your needle. Now, I have to be honest, I've never performed this classic sciatic nerve block. We do have ultrasound now, and I really believe in using ultrasound for blocks. I feel that if you use bony landmarks in combination with ultrasound and with nerve stimulation, that by using these various techniques, you actually will improve the success of your blocks. Now here is a view of a patient in the left lateral Sims position, and again the identification of the bony landmarks. And again, this is the classic approach to the sciatic nerve. Now I know years later there was another gentleman, I can't remember if it was Winnie or who, but he had you draw a third line from the sacral hiatus here on the medial side to the superior head of the greater trochanter, and by drawing this line, he felt that this line coming this way would intersect that line and that would compensate for the height of the patient. Now moving ahead, by using ultrasound, what you can do is identify those bony landmarks, just like Labatt described in 1922. You could take a low-frequency ultrasound probe and place it on the medial side of that line. You can then drag the probe in a medial caudally fashion down this way, and what you're going to see is you're actually tracking along the iliac bone here. The bone is this hyperechoic straight line, and what you'll see is as you come down this way, you're actually going to be coming right on top of the greater sciatic foramen. So what you'll see is kind of an enveloping of the bone, and on the lateral side you're going to see the sciatic nerve kind of come up off that lateral side. And I'm going to show that to you in a minute here on the next video. This is the posterior border of the ischium, and again you'll see this bone kind of fold down, and the sciatic nerve is going to be on the medial side of this posterior border of the ischium. Now this is actually me scanning myself. This is my left ilium. This is where the bony structure is. We could see the gluteus maximus muscle here, the gluteus medius muscle here, and this dot here is the lateral side. So once again, here is the ilium bone. It is hyperechoic, there's no reflections beyond it. And as I scan down my buttock area, you're going to notice on the lateral side here, this bone is going to kind of fold in and down, almost like a ski slope, and we'll look for the sciatic nerve in this area. And once again, this is the posterior border of the ischium. And you'll see how it's going to fold down, and then the sciatic nerve is going to lie right here. You can see it really good here. You can even see the little inferior gluteal artery here. Once again, I'm scanning in a caudomedially fashion. You can see the bone kind of curving. I'm going to actually track. There we go. I'm actually going to go back towards my head again, and you're going to see the ilium bone again. And then I'm going to track caudally and medially again. You're going to see this curve down, and you're going to see the sciatic nerve right there. So if we're going to block the sciatic nerve, look at the depth here, about 7 to 8 centimeters. We're going to use our nerve stimulating needle. We're going to come from a lateral side, so we'll be coming from here. And since this is the lateral side of the sciatic nerve, the common peroneal nerve most likely would be stimulated on this side. Since this is the medial side, this would be the tibial component. And this looks like the inferior gluteal artery, so we'll want to be cognizant of that. Again, I have to be honest, I have not done this block, and I'm not sure that I recommend it because when you're up this high, you have to think that the pudendal nerve is in close proximity, and we really don't want to block the pudendal nerve. And you also have to remember that we have a vascular supply in close proximity to the sciatic nerve at this proximal point here. When we move more distally down the sciatic nerve, chances are you're not going to see that inferior gluteal artery. Now moving ahead, this mid-gluteal approach is one of the two approaches that I think is worth mastering. Now in the mid-gluteal approach, we're going to be working more in this area here. A couple landmarks to remember: we have the greater trochanter on the lateral side, ischial tuberosity on the medial side. On the anterior side of the sciatic nerve, we have the quadratus femoris, and on the posterior side, we're going to have the gluteus maximus. Now, there was a researcher in Chicago by the name of Franco that actually took 12 cadavers and he dissected the sciatic nerve bilaterally, and he determined that the sciatic nerve actually ran in a common relationship to this mid-gluteal sulcus. Whether the patient was a male, a female, whether they were thin, whether they were obese, whether they were 7 feet tall, whether they were 5 feet tall, what he found was that the sciatic nerve was in this constant relationship to the mid-gluteal sulcus, or the butt crack. And what he found was it averaged about 10 centimeters lateral to the mid-gluteal sulcus. And you could see how the sciatic nerve actually runs parallel to the mid-gluteal sulcus. So Franco theorized that if he would put a skin ruler on a patient and mark 10 centimeters, he could take a 4-inch stimulating needle and just go straight in, and that he would get some type of stimulation of the sciatic nerve. So he did a study on 20 patients, and he actually had second and third year residents performing these blocks, and they, sure enough, 19 out of 20 patients, they were successful blocking the sciatic nerve with this simple 10 centimeters lateral to the mid-gluteal sulcus. So this was huge for myself when I was looking at a way to simplify this sciatic nerve block, because sometimes when you're trying to palpate the posterior superior iliac spine and the greater trochanter, depending on the patient's body habitus, it is sometimes very difficult to locate these landmarks. And anybody can identify a butt crack and measure 10 centimeters lateral to the butt crack. So this is basically the start of how we started doing our sciatic nerve blocks in a more simple fashion. So what you're going to want to do is measure your 10 centimeters over in this area of the buttocks. You're then going to want to apply a ultrasound probe. And when you apply the ultrasound probe, what you're going to look for, ideally you put the ultrasound probe down and then boom, the sciatic nerve is going to smack you in the face, but unfortunately that doesn't usually happen. What you're going to have to do is probably scan a little bit over to the lateral side, look for the greater trochanter, scan back a little bit on the medial side, look for that ischial tuberosity or the ischium, and then you're going to notice that the sciatic nerve lies a little bit more on the medial side versus the lateral side. Now this is an ultrasound view from Nisora, and as I said before, the gluteus maximus is posterior to the sciatic nerve, the quadratus femoris is on the anterior side, and there's a fascial plane between these two muscles, and the sciatic nerve lies in this fascial plane. On the lateral side we have the femur, and on the medial side we have the ischial tuberosity. The femur and the greater trochanter could be interchangeable or whatnot. I like this drawing by Jack Vanderbeek at neuraxium.com. And what he says is to imagine a gentleman laying on a hammock, and he's laying on that fascial plane, and there's a hole in the hammock, and his bottom actually hangs through the hammock, which is actually this fascial plane again. Now what I did is I actually flipped this picture around because I wanted you to see that the sciatic nerve normally runs more on that medial side when you're identifying the greater trochanter on the lateral side and the ischial tuberosity on the medial side. This sciatic nerve is normally more on the medial side at this level. And I want to go back and show you again. Here's a sciatic nerve. The fascial plane is here. So if we imagine the gentleman sitting on the hammock with his head over here and his butt over here and his butt hanging through this fascial area, that helps us identify the sciatic nerve. Now in this video, this is a video by Sonosite. I like it. It's about 2 minutes long, but it's going to show you actually scanning of a patient here on the laterals, and she's going to identify these things here. We have the greater trochanter on the lateral side, the ischial tuberosity on the medial side. This is how we apply the low frequency probe in the midgluteal area. We're actually scanning over the nerve area. We're going to identify the layers, well, first we have the greater trochanter, ischial tuberosity. We have the subcutaneous layer here, gluteus maximus, quadratus femoris, and then the sciatic nerve is here. I really like this video because they're going to show you the probe moving around. They're going to show you what the scanning looks like, and you can see as they're tilting and scanning, and at one point here they're going to go a little bit more distally, and you're going to see the quadratus or the biceps femoris muscle here, right there, really big, and the sciatic nerve is kind of sandwiched in here, and that would be going a little bit more distally. She points out the biceps femoris and the adductor magnus. Again, she's a little bit more distally. And then here they're just showing you the needle coming from the lateral side, getting underneath the sciatic nerve and injecting the local. I'm going to move on to the next slide here. I wanted to show you this video because this gentleman looks like he weighs 350, 400 pounds, and what they're doing is measuring the 10 centimeters lateral from the midgluteal sulcus, and you're going to see them take a it looks like a 150 millimeter needle and go relatively straight back. You're going to see them tilt a little bit and go more towards the lateral side, and as they're going in, you're going to see stimulation of the foot. Once again, I would prefer if they prop this up kind of on a pillow and left this foot hanging, because you really can't tell if we're getting dorsiflexion or plantar flexion because they only get a couple quick twitches here. I don't know if that's inversion or eversion. You can see the calf twitching. They're happy. They dial their nerve stimulator down. They inject their local anesthetic. He's going to withdraw his needle. He wants to impress you with the length of the needle here, so he actually measures the needle. Again, it looks like it's about 15 centimeters long. And I think it's funny here, they keep filming and they have the patient lay on his back, and he gives you the thumbs up. Pretty good. So again, this mid-gluteal approach, If all else fails, you can measure 10 centimeters lateral at the where the midgluteal sulcus is, and go straight in with a needle with a nerve stimulator, and you should get twitching of the sciatic nerve, and you can perform a sciatic nerve block this way. Again, I recommend using an ultrasound and looking for those different landmarks that I described. Moving on, I'm going to talk about the subgluteal approach. And Franco actually went on and did another study at the subgluteal area, and he found the same thing in his subgluteal approach, that measuring 10 centimeters lateral from the intergluteal sulcus, that the sciatic nerve seemed to lie in that exact same area. So he actually repeated his study on 20 more patients, having residents measure this out like this and using a nerve stimulator, and sure enough, 20 out of 20 patients, he was successful in doing the sciatic nerve block at this level. It bears repeating that at this level, in 50% of the patients, you're going to miss the posterior cutaneous nerve of the thigh. So if you're using this technique to numb up the back of the thigh, there's a 50% chance you're going to miss it. Now, this is a great video. This is one of my business partners, Scott Urigal, and again, you could see on the medial side here, we have the biceps femoris muscle, which is pretty large, and just lateral to that, you can see this hyperechoic density. This is the sciatic nerve. On the lateral side, we see the femur. He comes down with his nerve, and with his needle, and he injects his local anesthetic on the lateral side of the sciatic nerve. I'm going to move to the next. Unfortunately, in our facility, we only can we can only take 60-second videos. I do like his injection here because you could see the spreading in that fascial plane, and we know that the nerve lies in this fascial plane, so we know he's going to get complete spread around the sciatic nerve. Now, moving to the next video here, you're going to see Scott back his needle up all the way back almost to the edge of the gluteus muscle here, and then redirect it because he wants to get this medial side of the sciatic nerve. When you're doing this, he's not going to be able to back up and go over here. He's going to have to back up pretty far because these are very strong and thick muscles, and you really can't, it's really hard to torque your needle to get it to move short distances. So he backs it up really far, and then he re-angles, and you see him come down here on that medial side of the nerve. Moving ahead, I'm going to just briefly touch on the anterior approach. Now, honestly, this is another sciatic nerve block that I have never performed. I think it's very difficult because when you're coming from the anterior side, we're looking at depths of 9 to 10 centimeters from the surface, getting to the sciatic nerve from this approach. Now, there was an old method of using landmarks and identifying bony structures and having a needle insertion site very proximal, and the problem with that is with those bony landmarks, this needle insertion site was very close to the lesser trochanter, the femur, and many times when this block was being performed without ultrasound, people were contacting the femur bone on this edge. They would then walk off and direct their needle immediately, and they usually missed where the sciatic nerve was. Now, the anterior approach, I'm not sure the complete usefulness of using the anterior approach, but I guess if you had a patient that was unable to turn on their side, or you were unable to prop their leg up on some pillows, that you would be forced to do this anterior approach. But with the anterior approach, we're going to apply a low frequency probe on the thigh. We're going to identify a few structures. We're going to identify the femur, which shows up as this hyperechoic curved bone. We're going to identify the femoral vessels. We have the femoral artery. And then if we could identify the adductor magnus, which is this thick muscle on the medial side of the femur, the sciatic nerve lies in a fascial plane behind the adductor magnus muscle. It is said by some that you could actually draw a nice perfect triangle connecting the femoral artery, the femur, and the sciatic nerve. The triangle looks a little bit distorted in this picture, but I'm going to show you in this next video. This is actually me scanning my own thigh from the anterior side. Very obviously, we can see the femur. We have the femoral vessels in this area, so this is obviously medial. This over here is lateral. This is medial. And we're looking for the adductor magnus muscle, which looks pretty thick right here. So the sciatic nerve should be behind this muscle layer somewhere over here. So what I'm going to do is I'm scanning, I'm going to move more medially, and it looks like the sciatic nerve is right here. You can see the adductor magnus muscle, and you can see the sciatic nerve right here. And you can look at the depth here. I mean, we're talking 10 to 11 centimeters, so we're going to need probably a 150 millimeter stimulating needle. If we're going to come from the lateral side, we're going to have to direct that needle past the femur between the femoral vessels. So this could be very tricky, or we can come from the medial side, which would be coming from this side over here. Once again, I'm not really sure on the usefulness of this block, but I just felt it was important to cover it briefly. Our next approach, which is one of the two that I think you should master, is the popliteal approach to the sciatic nerve. If this is what the anatomy looks like. Now, if you do not have an ultrasound machine, the old method of performing this block was to identify the popliteal skin crease, go at the midpoint here, we'd measure 7 centimeters cephalad. We would then go 1 centimeter to the lateral side, and we would insert a needle straight in, and at 2 to 3 centimeters we should come in contact with the sciatic nerve before it bifurcates into the tibial and common peroneal nerves. Now we could see the biceps femoris border here, or the biceps femoris muscle, is on the lateral side. The semimembranosus and semitendinosus is on the medial side. If you need help in identifying these muscles, you could have the patient pull their heel up towards their butt, and you could kind of resist them with your arm, and you will be able to identify the borders of these muscles pretty readily. Now here is what it looks like with the tissue removed. Again, we have the popliteal artery here, kind of in the midline, and we'll notice that the tibial and common peroneal nerves lie lateral to the popliteal artery. And as we trace more superior, we're going to see how those nerves come together, and I'll explain that a little bit in a minute with ultrasound. Now, when you block the sciatic nerve at this level up here, you are sparing the hamstring muscles of the thigh, so you do give the patient the ability to crutch walk. Now, this is what the anatomy looks like, and again, these are drawings from Jack Vanderbeek at Neuraxiom. I recommend you go to his website and check it out. He's got some awesome illustrations, neuraxiom.com. But we could see on the anterior side, we have the femur, we have the popliteal artery, we have the popliteal vein, and located laterally to that, we have the tibial or sciatic nerve, depending where we're at in the posterior thigh region. Some people describe this kind of as a snowman. I'm assuming here he's demonstrating that he is compressing the skin layers a little bit, so he is collapsing the vein. He does have the descriptions of the landmarks here. Now in this next video, this is great because what I did is I took a high frequency probe, I put some gel on it, and I placed it behind my knee. And what I'm doing is I'm actually looking to identify the popliteal artery. Once I identify the popliteal artery, I know that the tibial and common peroneal nerves are located posterior and lateral to that popliteal artery. So here we go. I'm scanning. This is the lateral side where the dot is, and you can see I'm scanning more laterally. I'm actually looking for the popliteal artery, which is somewhere in this region here. I see some pulsating going on. So now I'm going to look laterally and posteriorly, and sure enough, the tibial nerve is right here. Again, the popliteal artery is somewhere in here, and the popliteal vein is somewhere in here. You can see again the tibial nerve. You can see the reflection of the femur here on the anterior part of the leg. What you're going to see me do at the end here is trace. I'm going to head more cephalad, and you can see the common peroneal nerve coming into view here. It's coming more from a lateral area, and it's going to join the tibial nerve, and it's going to form the sciatic nerve. I'm going to show you in the next continuation of this video. You can see again the tibial nerve and the common peroneal nerve separating, so I'm going more distally with the probe, and then I'm coming more proximally or more cephalad, and you can see them joining together, forming the sciatic nerve. And look how shallow this is, about 2 centimeters. So once we identify where the tibial and common peroneal nerves come together, we can approach this from the lateral side with a stimulating needle, and we can block around those 2 nerves. Now it's important to note that I'm scanning here with a high frequency probe, so at this depth we have a lot of really good detail. You can actually see the honeycombing of the tibial and common peroneal nerves. You can see them separating and coming together. So really good detail here. Now in this next slide, or next video, you're going to see my business partner Scott Urigal. He's actually coming, the lateral side is here. He's actually going to be, he's using a low frequency probe, and you can see the difference. The detail isn't quite as good here. The sciatic nerve is located here. We know that the popliteal artery is probably here or even down here, because we know it's going to be more medially and more anterior to the sciatic nerve. But you're going to see Scott come in from the lateral side here, and you're going to see him inject some local anesthetic on the anterior side of the sciatic nerve. He does back up, and then he's going to come on the posterior side of the sciatic nerve and inject on that side too. Now it's important to note here that some of these videos are really clear, some of them aren't as clear, and that's why it's important for you to know the relevant anatomical positions of the nerves in relation to the blood vessels at the different areas of the sciatic nerve, because you're not always going to have a perfect picture. You can see him injecting here on the posterior side. Now in summary, as I said before, I showed you 5 approaches to the sciatic nerve. If you can master 2 of those approaches, the mid-gluteal and the popliteal approaches, you should be able to cover any type of surgical procedure that requires a sciatic nerve block. Now remember, with the mid-gluteal approach, by using Franco's method, we're going to measure 10 centimeters lateral from the mid-gluteal sulcus, and this will be the entry point for our needle. Now when using ultrasound, if we could identify on the medial side, we have the ischial tuberosity, on the lateral side, the greater trochanter, and we want to look with ultrasound. We're going to see there's a fascial plane that's located between, on the posterior side, the gluteus maximus, and on the anterior side, the quadratus femoris. The sciatic nerve is going to lie in that fascial plane, more on the medial side. You should have no problems locating the sciatic nerve with these different tips and approaches. I also want you to remember that when you're doing the popliteal sciatic block, if you identify the popliteal artery first, we know that the nerve is lateral and posterior to that popliteal artery. As I showed you in those videos, you're going to want to track the nerve once you identify it more superior or more cephalad, where you see the common peroneal nerve join in with the tibial nerve. You're going to want to block the sciatic nerve at this level, and you'll have complete analgesia of the sciatic nerve from below the knee. That's all I have for now, folks. If you would like to email me with any questions, my email is jeffmolter@me.com. Thank you.